Hello, everyone. Welcome to DocTalks. I'm Dr. Manju George, the Scientific Director at Paltown Development Foundation, the nonprofit that supports COLONTOwn. And today we have with us Dr. Sharlene Gill, and she's going to talk to us about the challenge trial. And, as far as I've seen, everyone diagnosed with cancer, they want to know how physical activity impacts everything. So this is so great that you're here today to tell us more about the challenge trial. And I really applaud the Canadian team to have pulled a trial like this off. So, and then before starting with the actual trial results, my question for you, Dr. Gill, is if you could first introduce yourself and then tell us a little bit about how you got involved in GI oncology.
Oh, yeah. Oh, for sure. So thank you so much, Dr. George, for the introduction. I'm really delighted to speak to this group and to speak about exercise and cancer. I think it's the novel treatment we didn't think we were looking for, but we've now kind of identified. So it's an interesting question. So, my entry into oncology actually came about because I was a oncology pharmacist. And so and then while in medical school, I continued to work, and I thought this is really, medical oncology for me is really where I wanted to be. For GI oncology at the time, we're talking about 25 years ago when I was at the time when I did my fellowship. There was such a diversity within GI oncology. Like if we think about, upper GI, lower GI, hepatobiliary. At the time, it was uh, typically an older population. Not that that was my draw, but like just to highlight how much things have shifted in that space. And I just thought that there was lots of opportunity in GI, and so that's kind of what drew me to it. And just what we've all kind of seen in the last 20 years, especially in the last 10 years, I'm just very grateful that I'm in this space and have an opportunity to care for patients. I've never looked back. It's been was the best decision I made.
Okay, thank you so much. And then I would recommend everyone watch the TED Talk that Dr.
Thank you.
a few years ago.
Thanks so
Okay,
much.
okay, let's get on with the talk.
Okay, for sure. So I've called this from advice to action, and I hope over the next sort of half an hour or so, as we go through the data, that the reason for that title will be apparent. So we're going to be talking about the challenge trial, and the challenge trial is a randomized controlled trial that demonstrated with level 1 evidence that exercise improves survival after colon cancer. And so I'm a medical oncologist. I'm based out of BC Cancer in Vancouver, Canada. And I also have the privilege of serving as the chair for the GI disease site for the Canadian Cancer Trials Group, or CCTG, which was the cooperative group that led this trial. So if we, I'm going to, there'll be some back and coming in and out of the presentation that shared this data at ASCO 2025. I've left time for sort of questions and discussion because I think you'll find that the evidence is fairly self-explanatory. It's kind of more the execution and implementation that we're kind of trying to figure out as next steps moving forward. So the challenge trial is a phase 3 trial looking at the impact of a physical activity program on survival outcomes. So the primary endpoint was disease-free survival in patients with high-risk stage 2 or stage 3 colon cancer who had completed adjuvant chemotherapy. Dr. Christopher Booth, who presented this and was the first author, was a fellow at CCTG 17 years ago, at the time this trial was conceived. And I was a relatively junior member of the CCTG GI disease site at the time. And he kind of came to me with this idea, and to the group about doing a randomized trial of exercise. And it didn't seem like it would be possible, but I think this is one of the things that only a cooperative group can take on. So over the course of the trial, we partnered with the Australasian GI Tumor Group, AGITG, so the Australia and New Zealand And Jeanette Vardy was the lead investigator for that group. And then later on in the trial, UK also came on board. And so about 10% of the patients came from the UK. So it over the sort of trajectory of the trial was a multinational trial. And so at the time, Chris, came to us with this, idea as a very fresh-faced fellow. It was really on the basis of retrospective epidemiologic data that was consistently showing an association between physical activity and risk of recurrence after treatment of colon cancer. And Dr. Jeff Meyerhart from the Dana-Farber led a lot of this early work in terms of demonstrating this association between following patients over time after they've completed adjuvant treatment, and then looking at self-reported physical activity as measured by MET hours per week, and demonstrating that those patients who are more active had experienced better outcomes, better long-term outcomes. Now, as we know, the nature of retrospective data is that it can certainly help generate hypotheses. It can tell us a story, and there are sort of, there's biologic plausibility, there's a dose response. The more people exercised, the better their outcomes. And so many things that kind of would lead one to believe this is probably something real, but we know that there's lots of confounders there. And the criticism was always that in a non-randomized setting, how do you know that there isn't something about people who exercise that's just different? And so, that was kind of, the crux of sort of the argument. From the biologic plausibility piece, and these are slides, and I'm sorry the acknowledgement fell off my screen here, but that were presented by Dr. Meyerhart at ASCO when he introduced the challenge presentation. The biologic rationale, it kind of relates to the fact that we know exercise plays many roles in things like a metabolic growth function. So if we think about IGF-1, insulin-like growth factors, and their potential role in carcinogenesis, it plays a role in controlling inflammation and pro-inflammatory cytokines that also then have a role in carcinogenesis, as well as, progression of cancer. So we're thinking about cell proliferation, angiogenesis, and it has a role in immune function as well. Particularly, we think about immune surveillance, both from a prevention and a recurrence lens. And so, I think that biological plausibility is fairly robust. I think it's wanting to understand what particular aspect of that is driving it is still ongoing work, but it certainly made sense that exercise would be beneficial. But because it was observational data, it was felt that a randomized control trial was needed. And I will say that I work in a public health system, so in Canada, and one of the drivers for us within the CCTG to support this trial was that if we are ever going to be able to ask for public funding to support patients with cancer receiving an exercise program, we had to have level 1 evidence. So the strength of the observational data would not be enough for us to go to our provincial ministries and say, look, we need public dollars to support this. So that was the Canadian angle, was like, we knew our health system was going to demand this level of evidence. And so this is the schema for those of you who've seen, these trial schemas, fairly straightforward. It's, again, patients who've completed adjuvant treatment, high risk stage 2 or stage 3 colon cancer, 5-FU based chemotherapy. And then within 2 to 6 months of completion of adjuvant chemotherapy, they underwent baseline fitness testing to determine eligibility. So in the trial, on average, it was about 4 months after completion of adjuvant chemotherapy that patients were randomized. And the purpose of the baseline fitness testing was, as you can imagine, there are some people who are already coming into this quite fit. And so in a very fit population, to demonstrate a difference with an incremental improvement is going to be harder, right? And that's a small proportion, but some people were too fit. And then there are some people who don't have the fitness capacity to be able to engage in the structured exercise program. And so this did not exclude a significant number of patients, but it was trying to make sure that this was targeted to the population that was most likely to benefit. And then patients were randomized in a one-to-one fashion to receive health education materials alone. So I'm going to highlight this because it's really important, this question of advice to action. So all patients who were randomized were advised, even in the standard arm, that exercise is good for you. And the difference in the experimental arm was that they were also advised exercise is good for you and given health education materials, but then they were also enrolled in a structured exercise program that I'm going to explain to you. And it was a 3-year intervention. And so this is a few sort of example of this is actually the health education material that was provided to patients, but it's a 34-pager. I don't have all 34 pages, but it's a bit dated. So if we're talking about 2007, pre-AI and fancy graphics. And it was developed by Kerry Cornea, who was the other co-lead for the trial. He's a physical activity he's a kinesiologist, physical activity consultant based out of the University of Alberta in Edmonton, very widely recognized in Canada for his work in promoting exercise science in cancer, and actually recognized last year with an Order of Canada citation, because he's really been an amazing, tremendous champion. And so it's a step up to the challenge is what we called it. And in this 34-page document, it was kind of, why exercise is good for you, kind of a lay summary of the epidemiologic data, the other sort of benefits of exercise, and even a program that was laid out for people about how much they can walk. And so everyone received this. And then even people like me, and you can see how dated this is by my picture, provided little quotes to say, yes, please exercise, you should exercise. And so the control arm got this and the experimental arm got it. For the experimental arm that was enrolled in the structured exercise program, the target for the trial was to increase physical activity by 10 MET hours over their baseline. And so a MET is a unit of energy expended by sitting for 1 hour. So all of us sitting here for this 1 hour session will have expended 1 MET. An hour of brisk walking expends 4 MET hours. So to increase your MET hour, increase by 10 MET hours per week would mean an additional 2.5 hours of brisk walking per week. That's kind of the equivalent metric. And brisk walking, as Dr. Cornea describes it, is you look like, if someone saw you, they're like, oh, wow, Manju looks like she's late for an appointment. Like it's intentional walking, it's not strolling. And physical activity consultants at all the participating sites across Canada, Australasia, and UK worked with the patients. So the medical oncologist referred them, but it's really the PACs who did the work to create an exercise prescription. And so this was sort of the framework. And changing behavior is really hard. And this is, again, kind of this idea of, advice is often not enough in this exercise science space. And so most people may not receive that. And we know that a cancer diagnosis, and I don't have to tell you, is sometimes an opportunity where people really are rethinking what's in their control, how can they feel more empowered. And so it is a much more motivated, I would say, potential setting, but we still know that this is really hard. And so the structured exercise program was not just about exercise, it was a behavior change intervention. And it was a 3-year intervention split into 3 phases. And for those of you who are really interested in knowing the details of it, I will say that in the New England Journal publication, the supplementary appendix in great detail describes what was done at each of these sessions, including what the behavior change component was. So let me kind of lay it out for you. So in phase one, so if I'm in Vancouver, I would refer a patient. Dr. Kristen Campbell was our physical activity consultant based out at the University of BC. And the patient would be asked to participate in 12 mandatory sessions every 2 weeks over the first 6 months. And these were in person. And during that session, they would be going through a supervised exercise program, but also engaging in a discussion around behavior change theory. So really asking motivating questions, what are the drivers of decision making? What are your barriers to change? And then when patients would come back, there would be an element of accountability for these were the goals, what were you able to do, like your homework? And if not, if you weren't able to achieve it, how can we modify things? And even simple things like telling people, what if you leave your runners at your bedside before you go to bed, and then when you wake up in the morning, they're there. And so those really practical suggestions. In addition to the mandated sessions every 2 weeks, they were also encouraged to do additional, they were offered the opportunity to do an additional 12 sessions. So it could have been weekly if they chose to do that. And the goal in that phase was to reach that 10 Met hours per week increment. The second phase, which was month 6 to 12, the sessions continued every 2 weeks. They were mandatory attendance, but now they could be done in person or virtual. And one of the, if I can call it a silver lining of COVID, but one of the things that we learned by executing this trial during COVID was really honing in on the virtual platform. And that, as we are thinking about the knowledge translation piece and implementing this in practice, that data is very helpful to kind of know how, that's feasible to do this virtually. Canada, as many of you know, is geographically very vast. And so we have patients living in very remote communities up north. So from an equity, and accessibility lens, this was a really good learning. And then for the last sort of 2 years, month 12 to 36, mandated monthly sessions again could be in person or virtual. And so I hope you see this and you realize two things. One is that this was not a prescription of going to the gym and working with a trainer every day. This was really about providing that support, providing a program and a prescription. But most of the patients who participated in the trial were doing this on their own, right? This was they're kind of, it's either every 2 weeks or once a month, but it's being accountable and getting that guidance along the way that was critical to change the behavior. And the second was that it was I think a lot of the biological plausibility piece around why exercise is beneficial in cancer is related to cardiovascular exercise, not so much like strength training and pumping iron. And so this was, most of the activities were cardiovascular activities. So brisk walking or whatever worked in people's lifestyle, but it was cardiovascular activity. And so the primary endpoint I mentioned was disease-free survival. We know that in the adjuvant setting of colon cancer, this is a validated surrogate for overall survival. And then the secondary endpoints were overall survival, patient-reported outcomes, measures of physical fitness, which we'll talk about, safety, adherence, and then biomarkers, as well as the health economic piece. The last two is still work ongoing. That wasn't reported at ASCO, but they did report some of the other secondary endpoints. So over 15 years, actually, I'll come back to the power calculation and then I'll tell you. But the original power calculation was 962 patients for 380 events to detect a hazard ratio of 0.75 or a 25% proportional reduction in risk of recurrence or death or new primary, a hazard ratio of 0.75 for disease-free survival. So that would have translated into a 6% absolute improvement in 3-year disease-free survival, and it was an intent to treat analysis, meaning patients were analyzed in the arms to which they were randomized, as opposed to like what's sometimes called a per protocol analysis, which for something like this would have been very confusing, but people who actually did the intervention, right? So this was about an intent to treat. Um, but we, hit a lot of roadblocks along the way. I think when doctors Cornea and Booth called it the challenge trial, I didn't think they did it. It was kind of like stepping up to the challenge, but not that it would be challenging, but it was really challenging. It was, accrual was slower. Part of it was, for the centers that are used to doing oncology trials, getting infrastructure for a physical activity consultant to be a part of the team was work. That took time. We slowly engaged our international partners. That took time. And then the event rate was lower than expected, which is good for patients, but recurrences were, the estimated recurrence rate was higher than what actually was observed. And so that took time. So our Data Safety Monitoring Committee approved a cutoff at the end of December, end of 2024. So with 200 events at that time, that gave the trial 80% power to detect a much bigger delta, a hazard ratio of 0.67. So the risk with that approach would have been that, maybe we would have missed a smaller benefit. But it really was, it had gone on a long time, and we felt that this was really the appropriate time point to, close the accrual and close the data set. So over that 15 years, 889 patients were randomized 1-to-1 to structured exercise program versus health education materials alone. 55 sites were participating, mostly in Canada and Australia, as I mentioned. The median age is 61. So, but the range was 19 to 84, but a slightly, younger population, I guess, compared to if you look at medians. Half female, 90% were stage 3, and 85% or so received 80% received oxaliplatin-containing chemotherapy. And otherwise, there were no big differences in terms of the two groups. In terms of adherence with those 3 phases, so 83% of participants completed the mandated sessions, the every 2-week sessions in the first 6 months. 68% of patients completed the mandated sessions in the phase 2, the second 6 months. And then by end of phase 3, like 63% of participants completed the whole 3 years of mandated sessions. So that's actually, in exercise science, pretty good adherence to the program. From a safety lens, the only adverse event that was different was musculoskeletal events. So 7% more people in the exercise program reported things like sore muscles. You can call that an on-target effect or on-target side effect, but that was really it. 5 years into the accrual of the trial, we published sort of just a feasibility, like at 1 year from patients being randomized on the trial. We wanted to recognize that we were seeing a signal that this was feasible. And what we reported at that time, and at that point, about a third of patients had been enrolled on the trial, was that by self-reported physical activity, there was an increase in both, that's the first row, in both the control arm, health education material alone, or the exercise program arm. So that brochure maybe made a bit of a difference early on, but the delta was 10 met hours for the experimental arm. And then the other metric that's a very objective metric is the predicted VO2 max. And I like to exercise, but I'm not a kinesiologist. But my understanding is that is a very good index of physical functioning and aerobic capacity. And so at that 1 year mark, there was an improvement seen in predicted VO2 max in those patients who were on this, not super rigorous, but, prescribed exercise program. When we reported this at ASCO, when Chris presented it, these were the physical, sort of physiologic fitness metrics over time. And so self-reported physical activity, the 6-minute walk test, so how many meters they complete in 6 minutes, the VO2 max in terms of aerobic capacity, and then the questionnaire, the short form 36 on physical function, and a change from baseline. So for this one, the the lower the score, the better, meaning you're reporting less of an impact, negative impact on physical function. And what the important thing to highlight here is that the x-axis here is time. So over like, I think it's over 7 years, but over the 3 years in the intervention, this was maintained. These were sustained differences in the, which, kind of the hope is that this was not just a 3-year program, that there was true behavior change that is long lasting for the participants. So to the primary endpoint of disease-free survival and why we're talking about it, the challenge met its primary endpoint for disease-free survival, so a hazard ratio of 0.72, which translated into a 6.4% absolute difference at 5 years in disease-free survival, 74% to 80%. And if we look at it from sort of a number needed to treat framework, that absolute difference means that for every 16 people who exercised, one person was prevented from having a recurrence or a new cancer, which is a clinically meaningful number needed to treat. And if we look at the pattern of recurrences that were observed, the major impact seemed to be a reduction in recurrences in the liver, so distant metastatic relapse for those patients who were enrolled in the structured exercise. And interestingly, though not big numbers, but there was this observation that there were reduced new primaries, which biologically makes sense because we're talking, thinking back to the things we're talking about in terms of metabolic growth factors and pro-inflammatory milieu and those things. And for hormone-driven cancers like breast and prostate, we also know exercise has a role in androgen, estrogen regulation. And so this has kind of been, was not totally expected, but, an interesting observation, and reduction in new colorectal primaries, kind of speaking to a secondary prevention effect as well. Overall survival was a secondary endpoint that was also positive. So a hazard ratio of 0.63, which can think of it inversely. That translates into a 37% proportional reduction in risk of recurrence over time. And you see those, curves, as with most adjuvant trials, they start to separate sort of at the 4 or 5 year mark. And so at 8 years, the difference in overall survival was 7%. So from 83% to 90% for those on structured exercise. And that was primarily driven by colon cancer related deaths. And again, from an NNT, like a number needed to treat, you could say for every 14 people who participated in the exercise program for 3 years, exercise prevented one person from dying, which again is very clinically meaningful. When Dr. Booth presented at ASCO, he put this up as kind of just to kind of benchmark this against other drug interventions that have become standard of care in the adjuvant space, not just in colon cancer, but in lung. If you think of osimertinib and durvalumab, in breast, trastuzumab, and pembrolizumab and pertuzumab. And that 7% absolute improvement at 8 years falls well within what has been deemed to be clinically meaningful to change standard of care when we talk about sort of drug treatments, but without the toxicity and at a fraction of the cost. So the conclusions were that a structured exercise program. So we've tried not to just say exercise because, again, this is the intent is really to try to build capacity for cancer rehab physical activity consultants as part of a patient's cancer treatment team. And I think while this data is in the adjuvant setting for colon cancer, it's going to be hard not to extrapolate it to other settings, and because biologically, I don't think, and most people don't think, this is something unique to colon cancer. But that would be an extrapolation. It's a first-in-class anti-cancer effect demonstrated in a randomized controlled trial. And there is ongoing work within CCTG to look at sort of the secondary endpoints of biomarkers, health economics, and also predictors of adherence, trying to identify what were the barriers for those 1/3 of patients who were unable to complete, the mandated sessions over the 3-year program. this is a picture of Dr. Christopher Booth when he was presenting at ASCO, and on the second picture below, that's Dr. Carrie Cornea, who was the physical activity co-lead for the trial, for the challenge trial, and it was a simultaneous publication in the New England Journal of Medicine. And at the time when it was presented at ASCO in June, it did receive a lot of press internationally and in the Canadian press, which are some of the headlines on your left, and in the US press as well, really, highlighting that this is of interest, I think, to the public, to see that you can actually scientifically demonstrate a survival benefit with an exercise intervention. Um, you know, I may be biased, but this really does set a new standard of care. Historically, we've thought about exercise in oncology as a quality of life intervention, right? And it is a quality of life intervention that is a very meaningful value, but it is also a treatment, right? And should be viewed as such, and should be made available to patients. And from, again, our advocacy lens, we're trying to work to get this to be a funded facility for patients, not just a please go out and exercise if you can. Knowledge alone will not change patient behavior outcomes, and health systems need to invest in behavior support, really to move the needle on this in a population-based manner. It's empowering for patients. This is what patients have told us. It's achievable for patients. This is what we've seen in the trial. It's sustainable for health systems. Like, we've done some back of the napkin calculations and some more sophisticated calculations within my provincial health system, and this is quite literally like less than 1/10 of the cost, without a lot of the other health resource implications, and of course without the toxicity of a lot of other trials. So this is, this really has value. And I think it also reminds us of the power of academic cooperative trials groups to answer this question, that matters to patients. So in our, we have patient representatives in our cooperative group trials, and really, like most cooperative group settings, try to make sure that, we don't get boxed in and, oh, this could be really scientifically interesting, but really are looking big picture. Does this matter to patients? And I just think of the patients who chose to participate in the trial that I enrolled in Vancouver, and they were just so excited at this opportunity. They just completed their adjuvant chemotherapy, and it was, but the barriers were really about, they felt weren't sure they would have the time, and how would they manage this, and I think that's where it really highlighted that we need to provide that support as a program. Again, not just telling people to please go exercise. When it came out, just locally, I was trying, in our efforts to try to advocate for health system change, I published this in our local newspaper at the Vancouver Sun, but it's this idea of embedding exercise into survivorship care, and simply telling people to exercise is not enough. And I think we saw that, because I think we could have been criticized if the control arm was surveillance only, but because there was this active education component to it, and despite that, you see this improvement, you realize that it's really the exercise program intervention that made the change. And we need to sort of, build capacity and also eliminate structural barriers for patients to participate. This is just are some members of our CCTG group. Some of them you may be familiar with. And this was the picture on your left, was the bum run, which are CCRAN, the Colorectal Cancer Research Advocacy Network, one of our Canadian colorectal cancer advocacy groups, had held at our CCTG meeting in the spring. So a bunch of us went and joined. And then Manju mentioned this earlier, but I feel always very privileged to have opportunities to engage with patient groups and speak to patients, A, because I learn a lot, and B, because I think it's really important for us to remember that empowering patients to take control of their cancer journey is so important. And so when I did this TED Talk, it's been like 3 years ago, but it was just on the heels of COVID, and I was feeling a bit, I don't know, kind of like many people lost during COVID about what's finding my purpose. And working towards doing this talk really helped remind me why I do what I do. And I even today I'll have patients who will see me for the first time and they'll be like, I saw your talk and that really helped me to prepare for this consult even. So, and that means a lot to me. And so I'm really grateful for that. Um, so that's all I won't keep speaking here. But I would be happy to take any questions. Thank you very much.
Yeah, Dr. Gill, thank you so much. That was really very informative, and thank you for telling us about your TED Talk. I think one of the questions that I have for you is like, I'm really curious about the behavioral intervention part, because I think that, from Town, we know that like we have a healthy highway habit kind of group, because there are, already there are a lot of people who um, have been exercising and then they have colorectal cancer diagnosis and they're like, okay, we need to do this more. But like you said, the moment of diagnosis is like a really a point in many people's lives where they think like, they have to recalibrate their life, they have to stop living the way they did, and they want to make changes. So a lot of people look at exercise as a means for that. So I mean, my question to you is like, if from your experience with this 800, that's like a large number of people, like what has been some of the common things that people came up with, like why they couldn't exercise or why they miss sessions? And yeah, I'm kind of
Yeah.
curious. Yeah.
So I think a combination of things. I think that it's interesting you made the comment about like what at the time of diagnosis, and this is true in medicine across, disease types, but that moment of reflection of like, oh, and so on the one hand, I will say I have patients who are very active and then they get diagnosed and they're like, what the, like I've been doing everything and this still happened. And I can understand, anyone can understand how that's really demoralizing. And for them, it's the work is really trying to say that, there may be other aspects of how your cancer presented that were changed because you exercised, or maybe and or the biology of your cancer may be different. So we try to pivot a bit to encourage them to continue to not lose faith and stay active. And we know also the mental health benefits of exercise. There are also many ancillary benefits. Um, but the majority of people honestly don't, right? And many of our patients are still in their 60s and 70s and are not used to being engaged in a routine exercise program. We see that a lot actually in our less urban centers, where like sometimes in Vancouver, when Vancouver's West Coast is kind of a West Coast lifestyle, people are outdoors. We had more than a few screen fails, meaning people were too active, but that was not the case in our smaller sites, because in those communities people were not as active often and were able to participate. So the main barriers were the in-person sessions. Like, and so for many people, like they're, even though they finished their adjuvant chemo, so the intensity of their medical visits finished, they're trying to get on with their life and get back to work and all their family responsibilities that have been put on hold for the last year because of their diagnosis and surgery and chemo. So that was the big one, was I just can't go. And so you'll see that the initial drop off in the adherence was in that first phase, and then those who made it through that actually pretty stable through phase 2 and 3, especially when it allowed that virtual component. And then the second was, I think that like for um, like we didn't see, for example, we didn't see like weight loss. That was not something. And so some people were, maybe a little bit skeptical about, would this really, change my risk of recurrence? And I actually am, to be honest, I'm grateful that we didn't see weight loss because because of two reasons. One was that this isn't about, you know, weight loss, and it also reminds us that this is not, you don't have to do that kind of a change in your lifestyle in terms of diet and you're exercising every day, that this is something that hopefully is very achievable for the majority of the public.
Okay, that's really good to know. I think we have some questions. Let us look at those. Oh wow. Um, so this person says the prehab trial similarly found that supervised
Yeah.
training was more effective than self-directed exercise in improving functional outcomes following colorectal cancer surgery. The supervised program involved 1 hour sessions of aerobic and strength training performed 3 times per week with rest days in between. I have two questions about this. How important is it for for the exercise program to be scientifically tailored? Or can any varied and consistent exercise routine be just as beneficial? More importantly, if someone is highly self motivated and adheres strictly to their self developed exercise program or regimen, is it possible to achieve the same level of success as patients who receive private or supervised training? If not, where can we find hope that exercise, regardless of format, can still contribute meaningfully to survival and functional recovery?
Yeah, wow, very thoughtful question. Okay, so you know, the prehab trial, I think again, a really a much more finite time period, because it really was kind of as the lead up to surgery, but really demonstrated the importance of that supervised component. You know, I think we have to, from a generalizability and pragmatic lens, have to kind of not be too prescriptive about the physical activity. And that's why in a lot of the discussions around the challenge intervention, even though patients came in, had a baseline assessment, then the physical activity consultant crafted it, we've tried to say it could be as simple as like walking briskly for 30 minutes 5 times a week, right? To make it very, so that it doesn't land in a way that people feel like it has to be a scientifically structured program. That being said, I feel very strongly that you know, it's my responsibility as a advocate for my patients to pound the door and say, well, we should have capacity for patients to be referred to a physical activity consultant. So there's working, always pushing for that ideal. But I right now, what am I telling patients in clinic? Just that is that whatever you behavior change is about that motivation, but also you have to enjoy the activity you're doing. So if there are physical activities that you enjoy, you don't have to necessarily change them, but maybe we'll do more. We'll talk a little bit about kind of escalating that and really trying to be nimble and flexible with that, so people you know, don't feel overwhelmed by, oh my god, I just love playing pickleball, that's my whole thing, and now you're telling me I have to do this, and we don't want to do that. So you know, I don't know how well to answer your question based on the challenge trial. So for people who were already very motivated, like I would have people, they're like, you know, weekend warriors biking and everything, that they weren't eligible for the trial. The really high fitness functioning folks were not part of the challenge trial. But that being said, so what we don't know is, what is that, you know, do we tell them to exercise more? Like, does an increment of 10 met hours for someone who's already maybe doing this very high level of activity achieve the same benefit? You know, I don't know, but I think people who are self-motivated are engaging in exercise for a multitude of reasons. Often it is kind of that empowerment, physical functioning, your sense of well-being, you know, if you know that our mental health, we know, you know, how we manage stress. So you know, it's interesting, someone asked me once, they said, well, if the trial is negative, are you going to tell people not to exercise? and I thought, well, no, because we know that there are all these other benefits for exercise. But the value of it being positive was really trying to, I think, I think patients get it, but for health systems to understand that this requires a commitment and infrastructure. I hope that answers your question.
Yeah, thank you so much for that. The next question is, so I just wanted to make a comment. So it's really interesting that you did not see weight loss. So that, I mean, so basically what that says is that any amount of improvement, right? Like even if you did that minimum, though 10 met hours increase seems like a lot, but maybe not, right? Like for someone who's not doing anything, even that, like so even if you don't see a difference in your weight, you might still be benefiting from the exercise.
Right,
That's
right.
really,
Yeah. And that wasn't the goal. And and you know the other reason why I said we were kind of like, you know, if we saw weight loss, it's hard to see that just from this measure of exercise. So then it would be, oh, did people change their diet significantly? And is that what's driving it? And to some respect, you know, if starting to exercise it helps you to adopt other healthy lifestyle changes, that's great. It doesn't have to be, you know, related to the exercise. But yeah, it's not, you know, it was not like running 10K every week or something like that. Because again, most of these patients are in their 60s who are on the trial.
yeah. So we can go to the next question. Is there any evidence that the type or amount of cardio exercise makes a difference? The study looked at brisk walking, but do you think doing more of that or doing higher intensity exercise would have more of a benefit?
I think there is a dose response. I think that the study goal was 10 met hours per week, but you know, patients over the course of 3 years, many increased it by up to 27, 25, 30 met hours per week. So, and we know from the epidemiologic data that there is a dose response. The more people exercised, that their risk of recurrence was lower. So I do think if it's practical, it's part of your lifestyle, and you think it's something sustainable, then by all means, like you know, there probably is more benefit over time. But I think the key is trying to for people who don't exercise that much, really making it achievable, like and sort of. So I try to tell people you don't have to be doing that level of activity to see the benefit, but I do think there is probably a dose response to a point, right? It's everything's going to be to a point. Yeah.
Okay, thank you. This person says, I was running at least 5 times a week before diagnosed stage 2A, 224, low risk surgical treatment only. I continue to brisk walk 6 times per week, at least 4 to 6 miles, not only for physical activity, but mental. I hope it decreases my chances of recurrence. I do not attend supervised exercise. It's on my own.
That's yeah, thank you for sharing that. That's perfect. Like that's um the you know, you've already engaged in the behavior change component, which I think, as I said, I think was the biggest part of this supervision. It wasn't so much the exercise because you're already doing it, but it was the behavior change. So again, by no means am I saying we all have to have supervised exercise, but many of us do need that support for the behavior change component.
Okay. I just want to share what happened with me. So here, when I was diagnosed, there was a program at the YMCA, and somebody in COLONTOWN told me about it. It was called Live Strong. It was 12 weeks of exercise, but it is like any cancers. So
Yeah.
we would all go in there, and then they would tell us about the benefits, and then it was more like a structured exercise program, but not the part that you were talking about, the barriers, right? So then so during that 12-week time, we didn't have to pay for membership. And then after that, they encouraged us. So during that 12-week time, apart from this particular, 1.5 hours twice a week,
Yeah.
you were free to attend as many classes at the YMCA. And whether you wanted to do a lot more, a lot less. Like for me, I felt that I used to be always an active person. I did not run, I did yoga, I did like, I'd follow a YouTube video and do some 30 minutes of
Yeah.
physical activity, something like that. But this was really good for me because then that exposed me to strength training, to Zumba, like to so many other things that I had not done. And that made me, I got my family to come with me to the YMCA. And then we did it. So this was in 2018 when I started, and we did it till COVID in 2020. And after that is where, then we stopped going to the Y. So then, we were talking about like access to all of these. And, there was some discussion in a couple of groups in COLONTOWN where we were saying it'd be so good if, during the survivorship, like what you're actually trying to do is that the oncologist could like discharge us from their care and say, here is a year that you can be a
Yeah,
member in this place,
yeah,
something like that. That would have been like awesome, right? Like, because such
yeah.
programs are not
You know,
available in many places.
it's true. We were talking about barriers. So you know what? Cost is a barrier for people like to, especially again, you've come through this major life-changing event. You haven't been working for many people for a period of time. And then to just this idea of sign up for a membership to a gym. I like again, like I'm speaking of our Canadian system, which is the public health system. I think dollar for dollar, the return on that investment to me makes so sense. And I think it does land well with policymakers as well, but just trying to figure out how to make it happen. And our um, Dr. Booth, who I mentioned was the lead author. He's based at the University of Kingston. He's doing a lot of work also for us to nationally advocate for this. But exactly, that's what I would love. I would love to be able to discharge a patient and provide them not just the, okay, go exercise here, but actually send them somewhere where they're connected with someone who can kind of get them on track and help them to kind of do that. And I think it's so do I bring me back in a year. We'll talk about it. But I think I'm very confident that this is something that that will be a part of our health system.
So the other point that one of the things that you mentioned was about sustainability, right? So sorry, I'm getting some messages, but I think for me that was one of the things. Like, so my kids would laugh at me saying that's not running because I wasn't running,
Yeah.
And then, but then there were some studies which said that like to get benefit, you don't need to run. You need to like move faster than walking. And
Yes.
so they used to laugh at me saying this is like old people running, because
I know.
like, where are you going, mommy?
Yeah, kids can be harsh, but it's but that's exactly, yeah, it is not, it doesn't have to be running. And the point of the other thing that I didn't talk about, what I was going to make is we've seen this before. We've seen it in cardiac rehab as well, right? Where and the health system does exactly what you're saying, Manju, is they prescribe cardiac rehab, and patients after a cardiac event will go and have supervised exercise. So this is not something that is new in that sense, but new for oncology. Um, but I think that if we had said it's running, that would deter people, and thankfully the benefit was seen with a relatively modest but very diligent, consistent application of exercise. So I don't want to minimize that this wasn't work for people. This was definitely work for people, but very achievable.
Yeah, and I also want to say that like you had shared that booklet with me, so I will post when we have it in Colton University. I'll post a link to that because that's another. There were questions asking like, why are you not able to exercise, and what can we do? Like, I mean, I think that part is something that would be really of value, and I'm guessing the physical activity consultant probably they also helped in figuring out what those things were. So
Yeah.
maybe we have 3 minutes. My last question to you is like running such a trial. I mean, 15 years and taking so many centers, like I don't think it would have been possible in the US. I mean,
I think we had our doubts over time, but I'm just grateful that we are in an environment where we recognize the importance of publicly funded research, and why these kinds of questions just need that kind of infrastructure, whether though. So our Canadian Cancer Trials Group is a member partner of the NCTN, so and which is funded by the NIH, and we in Canada, interestingly, it's mostly funded by philanthropy, the Canadian Cancer Society. But this is something that only a cooperative group trial, could have done. But I think the crux was that patients really wanted it. Like, I think that would have ended the trial if there was no momentum, but our patient advocates within our group and patients we spoke to in clinic, but they felt it was a really important trial, and their participation is what made it happen.
Okay. My other question is like, you said that in-person visits were one of the major barriers. So do you think that after COVID and everything that we have learned, do you think that if it had more of a virtual component, would that have been different?
I think maybe the adherence would have been different. In 2000 and like 9, when the trial started, the idea of virtual training, and so people didn't quite, COVID really changed that. But this idea that, you might have YouTube videos, but those, having a live training session virtually just seemed very foreign. But I do think now, as we're thinking about implementation, a virtual component is huge, like especially for, again, not just people who have very significant time constraints, and also people who live far away. And it's so great that we can apply that now. So I think a virtual component will be key, and the trial was able to kind of confirm, at least demonstrate the feasibility of the virtual component through the second and third phases of the intervention.
Okay, thank you so much. This was very helpful. Thank you so much for your
Thank
time.
you.
I hope that, for everyone, like even in Canada, even in the US, like I hope this will push people to prescribe exercise for, survivors. And I think
Yes.
that and I'm sure that when you look, you might see a general improvement in health as well, right?
Yeah.
Which means
Yeah.
that for the investment, you're getting benefits in multiple ways.
Yeah, and even this finding of reduced primaries in non-colorectal related cancers, I think this is just amazing. So, thank you for spreading the word about this. I think this will change how we look at exercise as an active treatment, not only as a survivorship intervention. Yeah.
Okay. Thank you so much. Thanks to
Thank you.
everyone for attending. And a video will be posted in about 2 weeks with the transcript on COLONTOWN University. Yeah.
Thank
Okay.
you.
Thank you. Bye.